Hello, my name is Dr. Jonathan Edlow, and we're going to speak for the next 15 minutes or so about the diagnosis of reversible cerebral vasoconstriction syndrome. What is it? Well, RCVS, or reversible cerebral vasoconstriction syndrome, is a cerebrovascular condition of unknown etiology, and it's characterized clinically by recurrent sudden onset severe, also called thunderclap headaches. And it's characterized radiologically by reversible segmental narrowing of intracranial arteries. A little history is interesting. In 1986, Doctors Day and Raskin reported the case of a 42-year-old woman who, in retrospect, almost certainly had RCVS. She described a severe acute onset headache like being hit over the head with a hammer. Her neurological exam, brain CT, and cerebrospinal fluid were normal, and she was discharged home. She came back 5 days later after having two additional severe headaches, and an angiogram was done that showed diffuse vasospasm and also a 1 centimeter carotid artery aneurysm. The aneurysm was thought to be etiologic, it was clipped, and repeat angiography 1 month later was normal. This is a image from their original report, and you can see the vasoconstriction pointed out by those arrows. 2 years later, Colin Fleming from Mass General Hospital described four patients, and they titled their report Reversible Cerebral Segmental Vasoconstriction, and they recognized that other cases had been reported with different names. And over the years, many other cases were described in different circumstances, and again, there were various etiological labels applied. This is one list of the different names that we now know as reversible cerebral vasoconstriction syndrome, the Cough-Fleming syndrome, acute benign cerebral angiopathy, postpartum angiopathy, migrainous vasospasm, and many others. In 2007, Anish Singhal and his colleagues proposed that all of these conditions could be subsumed by the common term reversible cerebral vasoconstriction syndrome. We need to talk a bit about thunderclap headache because it's central to the presentation and diagnosis of RCVS. This is the results of a international series of patients. It's a registry, it's not a randomized trial, but of over 4,500 patients in the emergency department with headache, 14% of them had what would be termed as a thunderclap headache. The International Headache Society defines a thunderclap headache as having four qualities: severe intensity, abrupt onset, and they define this as a peak intensity reached within 1 minute of onset, a duration of at least 5 minutes, and there's no better explanation. And there's a problem that I have with this abrupt onset, reaching peak intensity within 1 minute. And the reason is that there's a Canadian study, which was a prospective report of over 2,100 neurologically intact emergency department patients with a headache that peaks within 1 hour. And of those 2,100 or so patients, 132 had a subarachnoid hemorrhage. And of those 132, about 82% did peak within a minute, but the other 18% peaked either between 1 and 59 minutes or at an hour. And therefore, I think that if you strictly apply that peaked instantly, you're going to miss important causes of thunderclap headache. This is a diagnostic algorithm that I use. We're not going to go over the entire algorithm because we're going to focus on RCVS, and we'll come back to this algorithm and deconstruct it a bit later in the talk. Females are involved much more frequently than males, in some reports as few as twice as often, in others 10 times. So female sex is much more involved and is a risk factor. The median age of these patients is about 50 years, but there's a broad range, between 40 and 60 or so. The official incidence figures are extremely low, but it's almost certainly an underestimate because a lot of people don't diagnose RCVS or didn't put it down as a discharge diagnosis. And only recently, in the last few years, has RCVS acquired its own ICD-9 code. So hopefully we'll get better epidemiologic data going forward. The proportion of thunderclap headaches with RCVS, there were two studies that informed this. A Dutch study, a very small study of thunderclap headache patients in whom aneurysmal subarachnoid hemorrhage had already been excluded, and about 8% of those were diagnosed with RCVS, and a retrospective Korean study of over 220 patients with thunderclap headache, of whom 8% had reversible vasoconstriction. In addition, there's the anecdotal experience of Anish Singhal, who reports that every 3 to 4 weeks for 2 decades, he's seen a new case at Mass General Hospital. So it makes sense to me that it's roughly the same proportion as subarachnoid hemorrhage, but it's not most people's experience. And there's a quote that's attributed to Hippocrates, and I'm paraphrasing, but life is short, art is long, experience misleading, and judgment difficult. And one's experience can be misleading if one really doesn't know about RCVS and therefore one never diagnoses it. If we took 100 hypothetical patients with thunderclap headache, then approximately, and these are rough numbers, approximately 8% will have a subarachnoid hemorrhage, approximately 8% will have RCVS, 1 or 2% will have other rare causes like a cervical artery dissection or a venous sinus thrombosis, and then the large majority will have benign causes like migraine or benign thunderclap headache. However, given the significant overlap in presentations, every patient with a thunderclap headache needs an evaluation for aneurysmal subarachnoid hemorrhage. The pathophysiology is unknown. Purported causes include sympathetic hyperactivity, serotonergic hyperactivity, oxidative stress, endothelial cell dysfunction, and others. And if you look at the list of triggers of this condition, it's clear that it's unclear what the etiology is. Pregnancy, especially the third trimester and the postpartum, is a trigger. Orgasm is a trigger. Hot and cold exposure, stress and grief reactions. So plunging into a cold body of water or taking a really hot bath are triggers. Sympathomimetic and serotonergic drugs, and then recreational drugs. And even if you look at the recreational drugs, cocaine, marijuana, LSD, even those have very, very different mechanisms. So the numerous physiologically disparate categories of triggers make assigning any unifying mechanism for this condition very difficult and troublesome. The clinical manifestations are multiple thunderclap headaches, a median of 4.5 over several days to a week or so, and 3 or more thunderclap headaches, different separate thunderclap headaches, is probably pathognomonic for RCVS. These headaches are relatively short duration, several hours, are often associated with nausea, vomiting, and photophobia, and you can imagine that it would be easy to assign migraine as a diagnosis to those patients. And I would point out that the duration of these thunderclap headaches is much shorter than the typical duration in a subarachnoid hemorrhage. The associated triggers are very common. Physical exam is often normal, and blood pressure may be elevated. There is no blood marker, no biomarker. If one were to do a lumbar puncture, the spinal fluid is usually normal or shows non-diagnostic trivial abnormalities like a slightly elevated protein or a few white cells or red cells. Brain CT is most commonly normal, but it may show a convexal subarachnoid hemorrhage. We'll come back to that. And complications include various forms of both hemorrhagic and ischemic stroke. Some associated conditions with RCVS at the time of onset are Takotsubo cardiomyopathy, transient global amnesia, posterior reversible encephalopathy syndrome, and cervical artery dissection. Some people have also said unruptured aneurysm, going back to that Day and Raskin case, may be an additional associated condition. This is an example of a convexal subarachnoid hemorrhage. It's high up on the convexities, not low down around the basal cistern, as you would expect an aneurysmal subarachnoid hemorrhage to be. And in this CT, you can also see some early hydrocephalus, which one would not see in RCVS. And this just shows you the two scans side by side. It would be extraordinarily unusual, and it's possibly one of those never situations that a subarachnoid hemorrhage aneurysmal would present with a convexal subarachnoid hemorrhage in the absence of a lot of blood in many other places, including around the basal cisterns. The convexal subarachnoid hemorrhage is found in 20 to 40% of patients with RCVS, and when present, it's almost always visible on the initial CT scan. In young patients, RCVS is the most common cause of convexal subarachnoid hemorrhage, and in older patients greater than 60 years of age, cerebral amyloid angiopathy is the most common cause, but these patients don't present with headache, certainly not a thunderclap headache. Other causes of convexal subarachnoid that may have a headache are venous sinus thrombosis, PRES, ruptured mycotic aneurysm, an AVM or moya moya. Cerebrovascular imaging is diagnosed, or diagnosis is by cerebrovascular imaging with angiography, often described as a string of beads or sausages. You being in Vienna right now, I would go with the sausages and maybe think about that tonight when you're going out to eat. A CT angiogram is fine. A catheter digital subtraction angiogram is not necessary. But there is one caution, which is that early angiography, meaning in the first week of the condition of any kind, whether it's CT, MR, or digital subtraction, can be falsely negative. And this is probably because of the progression from smaller, more distal vessels at the beginning of the illness to more proximal, larger vessels that are easier to visualize on an angiogram. And if this is the case and your pretest probability is high, a repeat angiogram in several days will usually be diagnostic. This is what you see, the string of beads or the sausages. Remember that part of the name is reversible. So here's a angiogram at presentation, and you can see three areas marked by the red arrows of vasoconstriction. And here, 4 weeks later, without any treatment, those areas are wide open again. There are two diagnostic scoring systems, but they're meant to do different things. The RCVS2 score is validated in patients that have both RCVS and other arteriopathies, and it's meant to distinguish vasoconstriction from other causes. And you can see that a thunderclap headache alone puts a patient much more at risk with vasoconstriction. And, you know, the headache of primary angiitis of the central nervous system, it's a much more indolent disease. It almost never has a thunderclap headache, and there's no rush to make that diagnosis in the first day or so. The second scoring system is meant to diagnose RCVS in patients that have a thunderclap headache. And this was validated in patients in whom a subarachnoid hemorrhage had already been excluded. And here, you know, the pattern of thunderclap headaches is more important. Is it multiple or single? Female sex is much more important. And then various triggering factors that we've already spoken about. So going back to the algorithm, the first step is always a non-contrast brain CT. And if that's diagnostic, then you go off and treat whatever you've diagnosed. And in the case of reversible vasoconstriction, a convexal subarachnoid hemorrhage would be the most common finding. If the brain CT is non-diagnostic, but a patient has had 3 or more thunderclap headaches, then you can do a CTA to diagnose what is almost certainly the case, which is RCVS. Again, 3 or more thunderclap headaches thought to be pathognomonic. If it's non-diagnostic, the CTA, and you still think it's reversible vasoconstriction, you can repeat it in a few days or go back through the rest of the algorithm to try to figure out what of multiple potential other causes might be causing the patient's symptoms. Complications, we've talked about convexal subarachnoid hemorrhage. Other forms of intracranial hemorrhage occur in 15 to 20% of patients, usually in the first week of illness, and that includes relatively rarely, but it includes subdural hematoma. Ischemic stroke accounts for 15 to 25% of cases. This is usually in the second or third week, but it can be a presenting symptom. And in one study of 159 patients younger than 45 years of age with stroke, reversible vasoconstriction accounted for 13% of those strokes. Despite all of these complications, though, the clinical outcomes are generally quite good. However, some patients will have some long-term neurologic disability, and rare fatal cases have been reported. So if you look for it, you'll find it. This is about the diagnosis of reversible cerebral vasoconstriction syndrome. Thank you very much for your attention.